So I'll be speaking on arthroscopic-assisted proximal tibia reductions and fixations. So as we all know, we have moved behind Schatzger's classification, and with more and more high velocity injuries and complex trauma, today we are not managing these injuries on the terms of Schatzger, but there are much more concepts like the column concept, and the fractures are even more complicated than just splits, depressions. There are rim fractures, associated avulsions, soft tissue injuries, much more to handle there. So when we speak of fixation of proximal tibia fractures, usually there are three modalities to do it. One is the standard open technique with a submeniscal arthrotomy. Second one is a fluoroscopic-assisted reduction. And third one is an arthroscopic assistance. The one thing is very important which we need to remember, that the tibial plateau surface, it's a surface and it's not a line. Therefore, whoever attempts to elevate these fractures under fluoroscopy, they have to take care that whole of the fracture is elevated and compressed well, sandwiched between the intact lateral and the medial surfaces. Because if the fracture remains mal-reduced, the chances of it getting depressed over the period of time are more. The disadvantage sometimes of a open technique are that we need a very larger incision to assess the difficult areas. Also, whenever we are viewing the depressed fracture, it's not a direct visualization, it's a visualization from side. Therefore, we also need to depend on fluoroscopy along with open direct visualization for the reduction. And arthroscopy has an advantage of assessing the difficult areas of the knee joint, which are sometimes difficult with even open techniques. And we can also directly end-on assess the fracture fragment. So the treatment goals of these fractures, they are on the basic principles of fracture management. We need an anatomical reduction, stable fixation, which will maintain the fixation on loading till it unites. We need to maintain the limb alignment and also need to manage the intra as well as periarticular soft tissue injury and minimize the complications. So arthroscopic assisted reduction, it improves the diagnosis. It allows us to evaluate and manage the reduction directly, and also utilizes way to manage the accompanying lesions there. So for prerequisite, we need to have a very good arthroscopy system, because as these are trauma situations, there is a lot of hematoma inside the knee joint and the fracture surfaces, they keep on bleeding. Therefore, unless a very good camera, we do not get a nice visualization there. The visibility, we have to even after arthroscopic visualization, we need to improve the visibility by some techniques which I will show. We need proper anatomical knowledge, instrumentation, and we also need void fillers when we elevate and fix these fractures. So surgical tactics while fixing these fractures are that as we are using more than one system or way to manage these fractures, we are relying on open techniques to open or percutaneous fixation of these fragments with screws or plates, using arthroscopy, along with that using fluoroscopy. Therefore we are jumbling more and more instruments during the surgery. Therefore, we need to stick to time. Therefore, assessment of arthroscopically and preloading the K or guide wires till the fracture site is a very important concept. We need to assess the fluoroscopic assistance of placement of that guide wires, because arthroscopy will not give us the way to assess where we need to preload the wires there. Therefore, fluoroscopy is most of the times needed. Prior clamp application, just putting the clamps at the fracture site in cases of split fractures is very important. Once you visualize the fracture arthroscopically, we can just dial the reduction with the clamp and then compress it with visualization. And we need to locate the depression, guide wire drilling, tamping, elevating it, holding it, fixing it, and then supporting it. So we need to go through these steps while fixing it. So this is the most common way of improving the visualization intra-operatively by arthroscopic means. We need to pass a PDS wire through a limb from above and below the meniscus, the lateral meniscus usually, to see the depression which is usually lying underneath the meniscus there. So you just put it and give a traction laterally, which opens up the joint in a figure of 4 position. So these are simple, some of the steps in various types of fracture which we fix. This is a split type of fracture. Therefore, you are preloading the K wires in the fracture fragment. preloading the clamp, assessing it arthroscopically, dialing the reduction and then compressing and then fixing it with the manure. This is the simplest type of a split fracture. Then when we have depressions, as I said, we need to assess the depression arthroscopically, preload the guide wire, usually through the medial side, because these depressions which we treat arthroscopy are usually posterolateral type of depressions. Therefore, passage of the guide wires from lateral to medial is difficult. Therefore, preloading it from medial side is a good choice. Once we elevate them, look it arthroscopically, then there are different techniques which are described. Once you have assessed the fracture surface, you just pass a guide wire, usually through an anteromedial surface till the fracture. You drill it with a 5 mm or a 4.5 mm drill bit and then pass a tamp to just elevate it and then just pass the preloaded wires to hold the fragment there. There are certain devices which are used by some people to aid in fixing these fractures. We need to fill the void which is elevated, usually with bone grafts. We usually do it with autograft. You can use a bio screw. Inside that you can use cement, you can use calcium sulfate. There are different types of things available. So one of the ways to actually assess where the guide wire should enter the depressed fragment is the arthroscopic-assisted zig, which we use ACL zig, which can be placed over the fracture fragment or the center when we need to pass in our elevation guide. Usually a Arthrex type zig, which is a flat zig, can be used with very well. So this is a case of a 34-year-old male who had a fall from height and a twisting injury. He had an associated ACL avulsion fracture. So we come across these fractures very frequently where we have ACL avulsion fracture or ACL tears with posterolateral depressions. These are his 2D CT scans in various views where we can see a good amount of defect posterolaterally. These are his CT scans showing the depression. And arthroscopic view, usually we see the posterolateral depression there, which was elevated through the same technique with the reverse Steinman pin type technique, which is assessed fluoroscopically as well. And once it is elevated, it is fixed with some screws. And this is post fixation, the arthroscopic view of the same fracture, which is elevated, showing good reduction and maintenance of the articular congruity there. So this is post-operative fixation where the ACL avulsion was fixed with a pull through and the fracture was supported with these two screws. Then there is also this technique described where they classify these posterolateral depressions in different types of tilts, where the tilt of the fracture is either posterolaterally, it is just lateral, or it is a central depression, and according to that we need to elevate it by these ways. And another case, a young male, he had an RTA, so referred with a tibial spine
how many more cases?
Just a minute, sorry sir. So he had anterior and a medial laxity, but if you see CT scan, it was a large posterolateral fragment which was flipped anteriorly, and this was the defect arthroscopically. So this flipped fragment was parked in the suprapatellar pouch. The ACL was reconstructed, and then through an open means, through a direct posterolateral approach, the fracture was reduced and fixed with a Herbert screw. So this is his post-operative images and the post-fixation arthroscopic view showing a good reduction of this fragment. So arthroscopic-assisted fixation is reproducible and reliable. We need better visualization. It allows us better visualization in difficult access areas, and it allows us to manage concomitant intra-articular pathologies. But I think it should still be preserved for simple cases of simple splits and depressions and not for very complicated proximal tibia fractures. Thank you.